Second white coat. Subscribe and like. Let's learn medicine together.
Welcome to The Explainer. Today we're diving into a real high-stakes medical mystery. We're going to follow the clues, just like an ER doctor, to figure out what's behind a patient's absolutely terrifying and life-threatening symptom. So let's get right into it.
You know, every great mystery starts with a single clue, and for us, it all begins with the patient's own words, the really alarming complaint that sent them rushing to the emergency room in the first place.
These 6 words right here: the worst headache of my life. In medicine, that phrase isn't just, a description, it is a massive red flag. When a doctor or a nurse hears this, it sets off all kinds of alarm bells. We're not talking about a bad migraine here. This is a signal of a potential catastrophe happening inside the brain.
So what on earth could cause a headache so severe, so totally different from any other pain someone's ever felt? That's the big question we have to answer. Let's start building our case file and see where the clues take us.
Okay, our first piece of the puzzle is the patient himself. He's a 55-year-old man. Right away, his age helps us start thinking about certain possibilities and maybe ruling out others. It's our starting point.
Now we get to the headache itself. And the key words here, the ones you really have to pay attention to, are sudden and abrupt. This wasn't a headache that kind of slowly built up over a few hours. No, this thing hit like a light switch was flipped. It went from 0 to 100 instantly. Doctors have a name for this. They call it a thunderclap headache because it reaches its absolute maximum intensity almost immediately. During the physical exam, we find another really critical piece of evidence: nuchal rigidity. Now that's just a fancy medical term for neck stiffness. Specifically, it means the patient has a really hard time touching their chin to their chest. This tells us that something is seriously irritating the meninges. Those are the protective layers that cover the brain and the spinal cord.
And here's where it gets really interesting. A bit of a twist. Despite this agonizing headache and the stiff neck, the patient's neurologic exam is completely normal. No weakness on one side, no trouble speaking, no blurry vision, nothing. These are what we call focal deficits, and their absence is just as important a clue as their presence. It tells us the problem probably isn't inside the brain tissue itself, but maybe around it. This helps us narrow our search in a big way.
All right, so we've got our initial findings. Now, let's do what any good detective would do. Let's lay out all the critical pieces of the puzzle right next to each other and see what kind of picture starts to form.
Okay, let's recap. We have that crazy fast thunderclap headache. We have neck stiffness, which points to irritation around the brain. We have a totally normal neurologic exam. But then we get this last piece of information from his medical history. He has something called autosomal dominant polycystic kidney disease, or ADPKD for short. Now you're probably thinking, a kidney disease? What does that have to do with anything? Well, as it turns out, this is the clue that's going to crack the entire case wide open.
So we have all of our clues laid out. Now for the big question. How does a genetic kidney disease lead to the worst headache of someone's life? This is where it all comes together. This is our aha moment. So first off, what even is ADPKD? Well, it's a genetic disorder, and it's most famous for causing all these cysts to grow in the kidneys. But here is the absolutely crucial point. It is a systemic disorder. That means its effects are not just stuck in the kidneys. They can show up in other parts of the body, including, as you might have guessed, the brain.
And here it is. Here is the connection. People with ADPKD have a way higher risk of developing something called Berry aneurysms. These are tiny, fragile little weak spots in the walls of the arteries at the base of the brain. You can think of it like a weak spot on a tire wall, just kind of bulging out, waiting to burst under pressure.
So, what happens when one of those weak spots finally gives way? The aneurysm ruptures. And when that happens, blood starts spilling out into the space that surrounds the brain. It's called the subarachnoid space. This whole event is what we call a subarachnoid hemorrhage, or SAH. And that sudden bleed is exactly what causes that explosive headache and irritates the meninges, leading to the neck stiffness. See? All the puzzle pieces, they just fit perfectly.
So we have a really strong working diagnosis. But in medicine, you can't just guess. You have to prove it. So what's the immediate action plan? How do doctors actually confirm a subarachnoid hemorrhage?
The workflow here is pretty standard and clear. Step 1 is to get an immediate non-contrast CT scan of the head. It's the fastest way to actually see the blood, which shows up as bright white on the scan. But
What if the CT scan comes back negative and we're still really suspicious? Then we move on to step 2, a lumbar puncture, also known as a spinal tap.
When we do a lumbar puncture, we're taking a little sample of the cerebral spinal fluid, and we're looking for evidence of blood. But more specifically, we're looking for something called xanthochromia. It's a yellowish tint that the fluid gets from the breakdown of old red blood cells. And finding that yellow tint is definitive proof that bleeding has happened, even if it was too small or maybe happened a little while ago and the CT scan couldn't pick it up.
Okay, with our diagnostic plan in place, we're well on our way to confirming this thing. But, a good detective always double-checks their work. So to really close this case, let's just take a quick look at the other suspects and see why our diagnosis is really the only one that fits all the evidence.
If we look at the other possibilities, none of them really fit. I mean, bacterial meningitis, our patient doesn't have a fever or any confusion. A bad migraine, that super sudden thunderclap onset makes that pretty unlikely. What about a different kind of bleed, one that's actually inside the brain tissue? Well, that would almost certainly cause those focal neurologic problems we talked about. But remember, our patient's exam was perfectly normal. All roads just lead right back to a subarachnoid hemorrhage.
And so, we can state our final diagnosis with a really high degree of confidence: a ruptured berry aneurysm, which was a complication of his underlying ADPKD, has caused a subarachnoid hemorrhage. The mystery is solved.
So, if there's one thing to take away from all this, it's this clinical pattern. When you see a patient with a known history of ADPKD, and they show up with a thunderclap headache, neck stiffness, but a totally normal neuroexam, your immediate thought has to be a ruptured berry aneurysm. That is the key pattern from this whole case. So, the case is closed. But, solving one mystery often just reveals an even deeper one. It's really just a powerful reminder that our bodies are all interconnected in these incredible, surprising ways, where a single faulty gene can cause huge problems in organs as different as the kidney and the brain. How is that even possible? Well, that's a story for another day.